Okay, so hi everyone, welcome back. This is the third of these interview videos trying to do with different health professionals amidst the ongoing lockdown while everyone's busy. Today, I'm very happy to be joined on the channel for the second time by Claire, who is a recently qualified GP practice nurse in the Portsmouth area. So today we're going to be chatting a bit about the transition maybe from being a nursing student to being a nurse, what a GP practice nurse actually gets up to day, and then how things have been affected by the ongoing, obviously, COVID situation. Thanks for joining us, Claire.
Thanks for having me, Ollie. It's great.
So, just have a quick summary. Who are you, Claire?
So, as you know, I'm Claire. I started my GP nurse job in February, 3rd of February. So I'm 2 months in now. It's all very new
Right?
in the middle of a pandemic.
What a time to start.
I know.
So let's start then. When I met with you the first time, we recorded a video together, which you can see earlier on the channel. I'll leave a link in the description, and we recorded one for your channel as well. Claire is a monumentally successful nursing blogger. So that was before you qualified. Obviously, now you're a fully fledged practicing nurse. So what's that transition been like?
It's been hard. Like, I can't say it was easy at all, especially the first, well, no, not even the first week. Actually, no. So going from student to newly qualified nurse, I felt like there was no in between. It was, you are the nurse now, and that's it. And for me, there was always something to kind of look forward to. So I was really looking forward to qualifying and then getting my overall classification and then starting my first day and then getting my blues for the first time. And then it was like, okay, I've got all of that. Now what? And it was like that period where I just relaxed and I was like, oh my God, like I've been through so much.
Yeah.
And 3 years is hard as a nurse at university. And then suddenly I am the nurse. And then there was a day where a patient just asked me something so simple, but my mind went blank in that moment. And I was like, I really don't know the answer to this. And then I put so much pressure on myself when I got home and I was overthinking it. And I was like,
Yeah.
I should know this. I've just done 3 years at uni. What have I learned? And so I felt really, really down for a good 3 weeks, probably.
Oh, dear.
Maybe.
Wow.
Where I was just like, oh, I'm not going to be a good nurse. But then I sort of thought differently about it. And then I thought, do you know what? We can't know everything. Like I always say this as well on my own channel to other people. You can't know it all. Nobody knows it all. Even top consultants will have to get advice from other people when it's not their speciality and stuff.
Absolutely.
And I've sort of taken the brakes off and put the brakes on and just sort of slowed down with my thinking. And anything I don't know, I've been documenting now and researching and revising. Little things like blood tests. So that patient asked me something about a blood test. So I can't remember what it was now, actually. It was something to do with the magnesium levels or potassium levels. And he was like, well, what is this? What does it mean if it's low? And I was just like, I don't know, my mind's gone blank.
Hypomagnesia is what it means.
It means you're low.
Yeah. Oh,
so I did a lot of research after that and revising, and I've got a whole page section now of each blood test, what it means if it's low, what it means if it doesn't work, all of that sort of thing. So that anyone asks me again, I can just go, well, yes, I know.
That seems, but that surely is that's how the process is supposed to work, surely. But that seems optimal.
It's lifelong learning, nursing, they keep saying, and they weren't wrong.
I can imagine. So that's the other element to this. So you work as a practice nurse, which is, I understand, very different to maybe being a hospital nurse. The type of nurses that I would come into contact with, which might be scrub nurses or ward nurses or matrons or whatever. Then you have the practice nurse. What's the difference?
Oh God, there's massive difference. So, like if you're in it depends where you work as well on a ward, I suppose. But in the acute sector, I find that it's more about managing those acute symptoms at the time or illness at the time, and then sending them home. Whereas our role as a GP nurse is to prevent them from getting to that point. But not only that, we don't sort of GP nurses, you have to be knowledgeable in many things. There's not just one particular speciality or anything like that. So we'll do things like hypertension clinics, then we'll have diabetics, we'll have things like asthma and COPD, we'll have the baby immunisations, we'll have travel vaccines, we'll have sexual health and contraception, we'll have smear testing, so all the gynae stuff, women's health stuff as well, like menopause things. There's just so much, ECGs. There's just so much that a GP nurse does, and it's all to prevent the hospital admission at the end of the day, if that makes sense. So we do a lot. I
guess I'd never really thought about that, to be fair. That's a really good so the idea is that it can be dealt with in community. So they don't need a bed, or they don't need to go to A&E or so and so.
We're trying to prevent it from getting to that stage.
Interesting. I guess, it's the same thing from the medical side of things. Obviously, we see a GP, I guess they are specialists who are a jack of all trades almost, maybe plus or minus special interest. Is that the same for practice nurses? Can you, if you want to do more gynae or peds, or do you have that option?
Yeah, definitely. Yeah. So as a practice nurse, you can definitely specialise. So each practice will have their own sort of diabetic specialist nurse, and then their own asthma specialist nurse and COPD management. They'll have a hypertension specialist nurse. So everyone will specialise in their different areas, but they'll all sort of chip in at the same time as well. So so one day they might do asthma clinics, but then the next day they might do some ECGs or wound management or something like that. So they do a bit of everything, but they also have their main specialism, if that makes sense.
Yeah, no, fair enough. I guess in the same way as most things. I mean, at what point, because this is, it seems almost ludicrous. I'm coming to the end of, well, we've done almost 3 years at medical school, and I still don't know the answer to this. What's the interaction between yourself as a practice nurse and, say, the GP or resident medic who happens to be there? What do you guys overlap in what you do, or is there much discussion that goes on?
Yeah, definitely. So I'm very fortunate. Actually, I think this is safe to say that it's across different GPs as well. We have a really good relationship between the doctors and the nurses. So I'm really comfortable. Like, I'll just go to a doctor's room and say, listen, I've got this patient and the leg looks infected or something, that I think they need antibiotics. Do you want to just have a quick look? And something like that. And it's really amazing actually how the GP doctors as well trust us as nurses, because they trust our judgment sometimes. Like, I'll say, I've done this assessment on a patient, this is my findings, they've got a bit of a temperature, it's looking angry, this wound, for example, is looking really angry and nasty, and they'll say, okay, I'll prescribe this and this for them, send them off. And sometimes they'll just trust our own assessments, which is really, really nice. But that's the only time we sort of work together in a way. Like, the GPs will always have their own set patients to look at and manage and diagnose, and we'll have our own set patients that we see. But at the same time, our patients will see them as well as us. Like, it's quite nice.
It's nice, that there's that sort of continuity, as it were. That's really nice. So we said before, obviously, you when we were chatting before this, you always wanted to do GP nursing. That was your kind of ideal. Has anything not been as you expected?
I don't think so. I think it is pretty much how I expected it.
Good.
But I think I didn't expect, like I was saying about putting myself under so much pressure at the time. I didn't expect that, and I always saw this picture in my head that I was going to be this great nurse and know everything and blah blah blah. But actually, it's not like that, and it is lifelong learning, like they say in nursing, and that's it really. And I think because at the minute I'm waiting to do my Fundamentals of Primary Care course. So as a GP nurse, you need to go on this course, which is about 8 to 9 months. And it's only like a day here and there at university, and then the rest of the time you're at the practice working. But it trains you to do those things, like the smear tests and ECGs, and well, I can do ECGs already. The baby immunisations and all of that.
Yeah.
So whilst waiting for that, I'm just doing the things that I can do. And I think I didn't expect to feel a bit useless, if that makes sense, because I'm seeing all these nurses doing amazing things and doing the asthma clinics and COPD clinics, and I'm just like, I want to be able to do this and I can't.
Yeah.
So it's that sort of feeling of maybe I'm not good enough and things like that I didn't expect. That's the only thing. But the job role and everything itself is exactly how I would have expected it. Does that even make sense? I don't know.
No, it doesn't. It's really important because for the benefit of listeners and viewers that are following this back, I'm going to tell you, because Claire wouldn't tell you herself because of who she is, but Claire is what most people would describe as like an exemplary distinction top end student.
Oh.
But you are, clearly, because I obviously was following you towards the end, and I think it's really important that even someone in that position who, you would have tracked as a top level performer can still have that sort of imposter syndrome, and that's a normal part of the process.
That's true.
So I think it's been really good. It's really important to highlight that if it's such a big change. I assume that's broadly similar if you went into a hospital trust or whatever. Whatever.
I think it is as well, because when I took to sort of social media and looked at other people's like newly qualified nurses, that how they were feeling and stuff, and it seems like everybody feels like that. This isn't just me, it's just everyone does feel like that, no matter what role you're going into as a newly qualified nurse. You do have that period of, oh my God, and uncertainty and questioning yourself and things like that. But people do get through it, which is good to hear.
Yeah, clearly we have lots of very excellent nurses everywhere.
Yeah.
So on the topic then of very excellent nurses, they will be bearing a huge brunt, if not the majority, of what's going on at the moment. So just thinking about your practice to start with, and I'll ask you a few more questions about this as we go. How has the ongoing situation affected things at the practice?
It's been very strange. As a GP nurse, it's been very strange. And I imagine on the wards as well, it's very strange at the minute and surreal. So our practice and our CCGs, I don't know if you know much about the CCGs, but they sort of manage us. They're like the top dogs.
Well, for the benefit of those, because I think mostly the people who listen to my stuff are either undergrads or pre-meds, as we would call them. What's a CCG? Because they need to know for their interview.
The clinical commissioning groups. Oh my God, I can't even remember the abbreviation.
Yes,
now.
That's
commissioning
right.
Groups. Anyway, so they are the people that are in charge of all the GPs. So you've got the clusters of GPs, all your GPs in your area, and then the CCGs at the top that manage them all. So our CCGs have been amazing. They've been really, really good. We've had daily updates. We've got PPE. We haven't got enough, but we've got PPE to last us until the next delivery comes. Yeah. The only thing we didn't have was things like visors, but a local school donated their science goggles to us. It was amazing. Wow. So we've now got a box of science goggles which are wipeable. You can clean them down and reuse them. It's fantastic. So yeah, it's been very strange, because when I first started as a GP nurse, I was like kind of supernumerary for the first few days. And then someone went off sick, so I said, "Well, I feel comfortable to do my own clinics now."
So what do you quickly mean? Again, just for the benefit of those unfamiliar, what is a supernumerary staff member?
So this is someone so I wouldn't be autonomous as such. So I would sit with the practice nurse and just sort of observe for a few days, just to get me into a routine, see how they do things. And the computer system they use in GP was something that I'd used before, so I was already familiar with the computer system. So I did say to them, because someone went off sick, so I said to them, I'm quite comfortable to take those patients, because it was blood tests, it was wounds, things that I could actually do. So I said, let me do this, because I'd rather get stuck in and do it than sitting around doing nothing, because I'm going to be bored. So from then on, I had like 23 patients a day, like every single day. I was really thrown into it on my own, off my own back, nobody else's fault other than my own. So it was all manic. But now, the last 2 weeks that we've been on this lockdown because of COVID and things, I've literally saw 3 patients a day, and I do 10-hour shifts. And this is purely because we had a big meeting about it, and management and CCG said, we want to protect staff. This isn't just about protecting patients. This is about protecting their staff. We need nurses at the end of the day to be around after COVID is gone. We want to protect you as much as possible before the peak hits, and make sure you're well rested, recharged, and only seeing patients that you absolutely need to see, so that when this peak hits and we do have every man on the floor, everyone's recharged and ready for that period, which I thought was a really good thing to do. So that's why at the minute, I imagine it's probably going to go on for another week or 2, maybe, depends when the peak hits us. We're all waiting for it. That's it. So at the minute, I am only seeing like 3-4 patients a day. They're sort of spread out as well. And everyone's like that. So the doctors and the other nurses, they've all gone to complete telephone conversations. So those that come in normally for the diabetic reviews and things like that, they're sort of doing them on the phone instead. And the doctors are doing like video conferencing and video calls with patients as well. So they're trying to do that. And the only patients we all see is those that we really, really need to. So if someone needs an ECG for chest pain, to say them to go to A&E, they're going to come to us. Things like the wound management needs to be kept on top of. Only certain wounds though. So things like leg ulcers, which are more prone to infection, so that person's risk of sepsis, never mind COVID. We need to see those sort of people. But if someone is happy to manage their wounds at home on their own, or if they've got family and things like that that can do it for them, living with them, then we've been giving them all the dressings and teaching them infection control and stuff like that, so that they can do it at home, so they're less risk. So it's all just change at the minute. It's really strange.
Incredible. So then next question is going to be student nurses. I've heard 2 different things about this. Now, I don't know whether you'll know more and might be able to enlighten me. In some places, I was under the impression that nursing placements had just continued. Like that they'd never been pulled from placements like virtually all medical students have, for example. I've always put forward that nursing students were much worse done by than medical students. And like, I don't think anything exemplifies that more than our placements being cancelled and the nurses being kept on. But I've also heard things that final years, because of relatively when you get your PIN or something like that, have been able to be pulled more quickly.
That's it.
Do you know anything about what's going on with that?
Bits from what I've read and hearing what other people have said as well, but looking on the NMC as well to just see what they're sort of doing. And from what I've understand is 3rd-year students that have got 6 months left have been invited onto a temporary register type thing, so they can they'll be 80% of their time out there helping out on the front line, and then 20% of the time is still continuing with the uni work that they've got. So if they've got any modules or anything that needs finishing off, they've got the time to do that as well. I've heard 2 different things about 1st-year students though. I've heard that their placements have completely stopped. They're being pulled off just because of the level of experience that they've got. They don't want to sort of overwhelm them and things like that. But I think what they're doing is shifting the modules around, so people are still doing their assignments and exams, but just not going out onto placement. And I assume later down the line they'll just catch up with those placements, so they'll sort of bring the modules forward and then have the placements later, I think.
No, fair. That's consistent with the sort of things that I've heard.
Something like that, yeah. And I think second years, from what I've heard, are still going on placement.
Yeah, I believe that, again, just what you see on social media, I think that things have just... I get, it's this thing that always baffles me. I think student nurses, because they're effectively staff. For those who don't know, there's a huge dichotomy between medical training and nursing training. Nursing training just appears to be much more hands-on and clinically focused. And they become, it seems to me, looking from the outside, that nursing students become both useful and competent far faster than medics do. And part of that obviously is due to difference in the courses and other various things. But the fact that these nursing students are being kept on doing what they were doing anyway, being valuable members of the team, but still not getting paid for it, because nursing students don't obviously get paid. And I don't know what's happening with the bursary at the moment.
Oh yeah, no, there is something about a payment as well that I missed out, actually. There is another, because there's 3 different options they can have. They've been given these 3 different options. I think one is to join the temporary register. Maybe this is for third years.
Well, we can go through it. I mean, it's all options, isn't it?
Yeah, I think join the temporary register or continue as a normal, doing your normal placements and workload and things like that, or to be. I read somewhere about being a band 4.
Good effort, if that's true.
HCA and a nurse, it's like that band in between, so you do a little bit of everything and getting paid for it. There was those 3 options, I think.
I mean, that's what I was using for comparison, was that because the agreement that my medical school have just made is that we're to be brought on as band 3s in the meanwhile, because we have various degrees of clinical competency but are not obviously far enough through the course to be able to be autonomous. I mean, F1s are not particularly autonomous anyway, like even if we were ready to graduate, which we're not. They need to sort out the situation with student nurses. That was terrible.
All a bit wishy-washy at the minute.
COVID aside, so we've gone through, obviously, transition to being a newly qualified nurse. Do you have any advice for student nurses at the moment, because obviously you've now crossed that threshold and facing the challenges that comes with that? You know, what you even say your past self a year ago, let's say, what would you say to Claire, third year nursing student?
Oh God, I would say probably prepare yourself, because probably in third year I was done. I think I was just like, I'm sick of exams. I'm sick of assignments. I just want to be qualified. I'm ready. Let me do it. And then the realization, like, oh my God, it is, you need to prepare yourself more, I think. I feel like there needs to be more at uni maybe to prepare you as well for it, that transition. And because I don't think anything really prepares you for the real going in there and becoming the nurse as it is.
So is it the case that you have preceptorship?
Yeah, so even as a GP nurse, we get like a preceptorship period, which it varies from trust, I think. So it can be anywhere between 6 months and 12 months, where you will have like that mentor still there to go to. If you need help and advice, you'll have like that named person, and you'll have like a work booklet or a folder or something like that of competencies to get signed off as you go, just to sort of ease you in a bit, I think, if that makes sense.
What might those competencies, just for illustrative purposes, what is a typical competency?
Oh God. I'm just thinking, I haven't even looked at my book. It'll be things like being able to do a blood test on my own. Would have to have been watched, and I did. The nurse watched me do the blood tests to start with to make sure I was competent, so that I could be signed off to do that on my own.
Yeah. How
to set up the ECG and do an ECG, little things like that, just to make sure that you are competent to do that on your own.
Okay. But even, you know, I suppose, so that, I guess I misunderstood where what a lot of places do with F1s, it may even be all of them now, is they do this assistantship period, where you, as a newly qualified doctor, well, you're not yet qualified, it's right before you qualify, you spend some time buddying an F1, so you're sort of doing the same job, but with someone who's currently doing it. So what I'm asking, I suppose, is there an equivalent of that, or
yeah, there is that as well. So like when I first started, I was always with the practice nurse to start for the first few days. So I would sit in with them and I would buddy them in a way. And it's the same on wards from what I've seen from other people's tweets and things like that, that they've had like 2 weeks, sometimes 3 weeks of that period where they're just shadowing. They've got that one person to sort of follow around, if that makes sense.
Yeah, no, fair enough. I was just, but I guess what prompted that question was you do you feel or not that period for you did adequately prepare you or not?
Oh yeah, that's a good point. I don't think it did.
Yeah,
I think
that was kind of the feeling that I got.
It's all down to, I think, myself. It's the pressures I put on myself. I don't think it was anybody else, if that makes sense. Like I could have had weeks, I think, of just sitting around with somebody, but I would have still at some point put that pressure on myself, thinking, oh my God, I can't do this, because I think that's just the person I am, and I need to be a lot more kinder to myself. So I think for other students out there, I think you just need to remember to be kind to yourself and just take each day as it comes, and always ask for help. Speak to your people if you need help.
Yeah, that's a really crucial message, I think, particularly at the moment with things as they are. I'm just preparing at the moment for, we have these situational judgment exams. I have them coming up at the end of the year, and basically the correct answer to everything that they prompt you with is always ask for help as quickly as possible if you don't know what's going on.
Well, that seems like a good answer.
Well, hopefully helpful. So then looking ahead then, we're still 2 weeks, 4 weeks, 2 months, but behind this peak that's going to hit, depending on who you listen to, on any given day of the week. What feelings do you get about how, you know, from your perspective, how things are gonna potentially be?
So I think from like a GP, I can only talk about GP sort of point of view, and district nurses as well, I can probably add into this.
Sure.
We will be doing the home visits. That's what we're going to be doing. I think there's talk about it. I've seen it in a bulletin that there's a talk about it. So obviously, oh God, I don't want to get too much into this because I'll end up crying or something.
Oh dear.
But there's been a lot of talk from what I've seen. I don't know if you've seen it as well, about the ethics around it all, and decisions are going to be made, and these difficult conversations between patients of who's going to survive it and who's not going to survive it.
Yes, yeah.
Those people are going to be sort of sent home, and that's going to be our job. I think that's going to be GPs and district nurses to manage those patients at home. So
these are patients who would be, just for clarity, these are people who would be potentially very, very unwell, but maybe aren't good fits for ICU. Yeah,
exactly. Although something I didn't realise about ICU, which is going to make me sound really dumb, I don't know, but I only found this out in my second year of training, that I didn't know that you only went to ICU if you had a positive outcome. You would never get sent to ICU if you weren't going to make it. And that really shocked me.
It sounds a bit heartless, doesn't it?
A person to save them. It baffles me. And so when all this come out, I think it might be, if someone like me, when I didn't know that back then, it might be a shock to some people to hear that. But that's something that we've always done, obviously, in nursing and medical professions. If there's no positive outlook, they don't sort of help you as much. I don't know how to phrase it.
maybe the care pathway is different.
Yes, care pathway is different. If you're not
Diplomatic response.
So yeah, and looking at it, they're sort of looking at comorbidities. They're not just looking at age, because someone might have a really good quality of life at 80.
Yes.
They might not have any comorbidities, and they might have actually a really high success rate.
Yeah, no, it is. I think a lot of people are shocked when they find out. There's this view. This is common, I've found, among medical applicants as well, where when it's come up when we've been talking about interviews and things, that the role of the healthcare system in general is to provide all help at all costs. But that's just not true. That's not the reality of how the service is set up to work a lot of the time. Because I guess you get into a discussion about equitable use of resources, and if you have the view that someone's going to sit on a ventilated bed for 3 weeks and then die after those 3 weeks, well, it wasn't a good use of that bed, then maybe if you thought that going in.
And is it kind to the person to do that to them as well? That's the other thing.
Don't know. What do you think about the, I'm sure you've seen the Nightingale hospital.
Firstly, it's incredible that they've just put up these hospitals. I think it's amazing. But it just shows the scale of things, and it shows actually how bad it's going to get. They built a hospital in the Excel Centre, London, that's going to have 4,000 beds. That must show you the impact of what this is actually going to do. It's just, yeah.
It's staggering, isn't it?
It's crazy. But I love it. I'm seeing posts and stuff of people getting jobs there and stuff like that, and I'm like, wow, these people are amazing.
Yeah,
Heroes of the NHS.
Yeah, medically qualified friends of mine that I spoke to recently being roped in to sort of head up various education programs that are going on there. It's absolutely, I guess, well, unprecedented, isn't it? If you were to summarize this whole situation maybe in one word, it's our health system just clearly was not built or set up with something like this in mind. Here's a question for you that maybe the last proper question I'll ask is, when all this is said and done, you know, whether we're 1 month, 2 months, 6 months down the line, do you think the NHS will be the same afterwards?
That's a good question. I mean, in my head, I'm thinking it's not going to be the same. Absolutely not. I think it's going to be better. That's in my head. I mean, in my head, everything's rosy. So this could be like a fairy tale. But in my head, just seeing the way things are working at the minute, I'm seeing chief execs being roped in to do a completely different role to what they used to. They're going to see actually how hard their colleagues are working and how amazing they are. The public, I think, are going to look at the NHS completely differently. Like, I've been speaking to a couple of people that work in A&E, for example, and at the minute it's dead. The regulars aren't coming, sort of waiting for the peak like everybody else. So I think if this goes on for a longer period of time, people might get into a bit of a change in behaviour as well with it. And this is just me, speaking freely, sorry. And I think people will realise actually that they don't need to put that pressure on the A&E anymore. They don't need to come to a GP nurse because they've cut their finger. They can manage that at home. I think there's going to be a lot of changes in patient behaviour. There's going to be a lot of changes in the way chief execs and management and even government see the NHS and nurses and doctors. I think we might actually get some recognition. All of us, doctors as well as nurses, healthcare assistants, will become out stronger and better, I think, than ever. Like, genuinely.
Here's hoping.
Let's hope, anyway. Fingers crossed, guys.
Fingers crossed. And on that most positive and hopeful of notes is where we'll leave this. I've already taken up way too much of your valuable day off, which Claire has donated some of her day off to speak to me. So thank you very much, Claire. It's been a really interesting insight into what's going on with you. Thank you for spending the time with us today. We'll put links to Claire's social media and things down in the video description so you can catch up with everything she's doing, which I encourage you to do. And thank you, Claire. Take care.
Thanks, Ollie. Thanks, everyone.
Okay. Thank you. Bye. Thanks for watching, guys. There are 3 ways you can support the channel. The first one is to like, comment, subscribe, share this video with a friend. Just enjoy it generally. Second, you can buy me a coffee if you found it useful using my Ko-fi link, which will help keep me awake during the editing process. And then thirdly, you can use my referral link to save 10% off your first year of Complete Anatomy 2020, my favourite 3D anatomy learning tool. Take care, guys, and I'll see you next time.